Hi dear doctors, welcome to 𝗲𝗵𝗵𝗆. I am Dr. 𝗲𝗵𝗵𝗺 and I am your pediatric faculty. Now we'll discuss about the patent ductus arteriosus. See, understand patent ductus arteriosus is a pediatric cardiology topic, and this is the fifth video which we are going to deliver today. Now, patent ductus arteriosus, in order to understand, you have to understand that what is actually the ductus arteriosus. Okay, what is ductus arteriosus? So can you see, this is the aorta which is going on, okay, this is the aorta, and this is actually the pulmonary trunk. This is the aorta and this is the pulmonary trunk which is there. So pulmonary trunk is going to send it to the the aorta and the pulmonary trunk are going to get connected. Okay, they are connected actually, and just because they are connected, so what you have to understand that this connection is actually called as ductus arteriosus. This connection in the embryological period is called as ductus arteriosus. Okay, ductus arteriosus. Let me just check if I've got another picture of it. Yeah, so, okay, so remember, this is the ductus arteriosus which is there. Okay, now, so ductus arteriosus, what is the importance? Why the ductus arteriosus exists? So let me just quickly tell you about something in embryology. So what happens in embryological period of time, the lungs are actually not mature, lungs are immature. So we want, okay, we desire that a less amount of blood should reach the lungs. Okay, so I just require that a less amount should reach, okay, I just demand that a less amount should reach the lungs. Okay, you getting it? So yeah, so less amount should reach the lungs. So now what is important is that this is the heart. Okay, this is the heart. Okay, I'll draw like this. This is the heart. This is the left side of the heart, and this is the aorta which is coming out, and this is the pulmonary artery which is coming out. So what in the embryological period, what happens, there is a connection between these two, the pulmonary artery and the aorta. Why? Because any amount of blood that is going to go to the pulmonary artery, with the help of this connection which is called as ductus arteriosus, this is going to come to the aorta and will get to the systemic circulation. So this way, aorta and the systemic circulation will have more blood, whereas pulmonary artery will have less blood. But once the fetus is born, so this is actually about the fetus, but what happens if it is an infant? This is going to get closed so that good amount should reach the pulmonary artery. So ductus arteriosus is going to get closed. Okay, but for example, if it is open, then what is going to happen? Of course, the left side is stronger than the right side. That's why a lot of blood is going to go from the aorta to your pulmonary artery. A lot of blood is going to go from your aorta to your pulmonary artery. Okay, but please remember, the blood is going to go from the aorta to the pulmonary artery. That's why it is very good thing for us, because the cyanosis is not going to occur, and this leads to what? This leads to the acyanotic heart disease. This leads to what? This leads to acyanotic heart disease. So this is an important background, whatever I've told you. So what is the definition of patent ductus arteriosus? It is a persistence of the ductus arteriosus after birth, which normally closes within 15 to 30 hours, and it is completely fibrosed by 3 weeks. So 30 hours and 3 weeks you have to remember for the patent ductus arteriosus. Okay, so patent ductus arteriosus, please understand, normally it closes by 30 hours, and 3 weeks is the time which it is required for complete obliteration of it. Now, why there will be a patent ductus arteriosus? Why there will be a patent ductus arteriosus? So sometimes, the premature babies, okay, so what happens in premature babies? The lungs are not mature. Okay, so premature means the lungs are not mature. So because the lungs are not mature, of course there is no point in giving higher amount of blood to the lungs. So that's why this opening gets remains patent, premature. And one you have to remember is rubella. Okay, so rubella. So please remember PQR. Okay, so R for rubella and P for patent ductus arteriosus. Q is actually not important, so you can just cut this Q. P and R are important. Coming on to pathophysiology, I have told you, let's just quickly revise this pathophysiology, that in fetus the blood is going to bypass the lungs via ductus arteriosus. Okay, why? Because of course there is a increase in the pulmonary vascular resistance. Why there is an increase in pulmonary vascular resistance? Because the lungs are not mature, then the vessels, the cells are not going to take the blood. No, the endothelium which is going to be there in the lungs, they are not going to take the blood because the cells are not mature. So that's why there is a high resistance that is going to be there. Okay, plus there is a constant release of prostaglandin E1. Prostaglandins are going to do what? Prostaglandins are actually responsible for causing the vasodilatation. That's why both of them are responsible for keeping it open. After birth, what happens? The pulmonary vascular resistance is going to decrease and the systemic vascular resistance is going to increase. That's why there is a reversal of the flow. So if it is patent, now it is going to go from aorta to the pulmonary artery. So similar to the ASD, VSD, the left to right shunt is going to come, the left ventricular volume is going to deplete, the pulmonary is going to be over circulated. That's it. Okay, now see what happens actually is that if there is decrease in amount of prostaglandin E1 and if there is increase in amount of oxygen, this actually leads to the smooth muscle constriction. So once the lungs are developed, please understand, if the lungs are developed properly, there will be prostaglandin E1 decrease and there will be what? There will be increased oxygen. That is also going to do what? Smooth muscle constriction, and that leads to the functional closure. Okay, but there is anatomical closure also. What do you mean by anatomical closure? The fibrosis which I told you. Okay, and anatomical closure, this remains as a ligamentum arteriosum. This remains as a ligament. There is actually a connection between the, I don't know if I'll be able to show you or not. There's actually a connection between both of them, the pulmonary artery and the aorta in us also. That is called as ligamentum arteriosus. It's actually a remnant of the ductus arteriosus. Okay, remnant of ductus arteriosus. What are the clinical manifestations? Just like ASD, just like VSD, if it's a small, asymptomatic. If it's moderate, so in moderate conditions, what is going to happen? Exercise intolerance. See what is happening, that in exercise you need blood. Okay, in exercise you need blood, but because the blood is going away from the aorta, there is decreased supply which is there. That's why there is exercise intolerance. So dear students, there is a wide pulse pressure which is going to occur. So now see, understand, there's a slight difference between the ASD, VSD and a PDA. PDA is having of course the left to right shunt is going to be there, but can you see that ultimately that from the right side it is going to come to the left side only. Okay, you got it. The blood is going from aorta to the pulmonary artery, that's considerable, but even if it is going to the pulmonary artery, it has to go to aorta again. Okay, so that's why what happens is that the systolic blood pressure is going to get increased and the diastolic blood pressure is going to get decreased because the vascular resistance is low. That's why the systolic blood pressure minus diastolic blood pressure is going to be very high, and this is something which is called as a wide pulse pressure. This is called as wide pulse pressure. And since a lot of blood is going to come to the left side, because aorta's own blood is coming, then pulmonary artery is also bringing the blood, this leads to the left ventricular hypertrophy. Okay, that leads to what? That leads to left ventricular hypertrophy. So this is important, and the left ventricle, because it is hypertrophied, it is related to the displaced apical impulse. In large PDAs, there will be failure to thrive, heart failure and left ventricular volume overload. Why there is failure to thrive? Because less amount of blood is going to the tissues for the growth. Why there is heart failure? Because left ventricle has to put in a lot of effort. Okay, left ventricle has to put in a lot of effort to push the large amount of blood which is coming. So that's why here it is a left ventricular volume overload. Whereas in ASD and VSD, my dear friends, there is a right ventricular overload which will be there. Okay, here there is not right ventricular overload because no blood is going to the right side. In fact, the more blood is going to reach to the left side, because the pulmonary artery is also going to the lungs and then supplying the blood to the right side. Okay, you got it? Yeah. Machinery murmur or the continuous murmur. Okay, so this is important. You have to understand that there is a murmur which is called as continuous machinery murmur. Okay, continuous machinery murmur is seen in the patent ductus arteriosus. Okay, so this is important. Continuous murmur or the machinery murmur, this is important. And the very simple way to remember this is PCM, paracetamol. P for patent ductus arteriosus, C for continuous murmur. Continuous murmur is also called as machinery murmur. Okay, or if you don't want to use this mnemonic, you can remember who can work like a machine, who is patent. Simple. Who can work like a machine? The one who is patent. So machinery murmur is seen in patent ductus arteriosus. That's it. What is 𝗖𝗵𝗿𝗺ization of PDA? Okay, now let us understand about this. This is very important concept. What do you mean by 𝗖𝗵𝗿𝗺ization of PDA? So as I have told you that in normal PDA, what is going to happen? A lot of blood, please understand, a lot of blood is going to what? A lot of blood is going to from your aorta to your pulmonary artery. You got it? A lot of blood is going to go from your aorta to your pulmonary artery. Now because it is going from aorta to the pulmonary artery, gradually what happens, the musculature of, okay, so gradually the musculature of your pulmonary artery is going to get stronger, and the reverse is going to happen. What is the reverse? That the pulmonary artery is going to go and supply the aorta now. So this will lead to decreased blood supply to the lungs, and the patient might suffer from cyanosis. Okay, the patient might suffer from what? Cyanosis. So this is 𝗖𝗵𝗿𝗺ization. But in patent ductus arteriosus, the cyanosis is a differential cyanosis. Even if it is occurring, this is going to be what? This is going to be a differential cyanosis. Is in the 𝗖𝗵𝗿𝗺ized or 𝗖𝗵𝗿𝗺 patent ductus arteriosus. This is going to be a differential cyanosis. This is going to be a differential cyanosis. Why? So for understanding the concept of differential cyanosis, please understand that this is the left subclavian. Okay, this is the left subclavian artery. This is the common carotid artery. This is the common carotid artery. Okay, and this is the brachiocephalic trunk. This is the brachiocephalic trunk. Okay, and these three branches are actually responsible. These three branches are actually responsible for supplying the upper limb. Okay, for supplying the upper limb. And if you can see carefully, after giving the blood supply to the left subclavian, the common carotid and brachiocephalic, then there is 𝗖𝗵𝗿𝗺ization. So the less amount of blood is going to enter into what? The less amount of blood is going to enter into the descending aorta. Okay, less amount of blood. So this is actually descending aorta. So less amount of blood is going to enter into the descending aorta. So less. So and this descending aorta is particularly supplying the lower limb. Okay, so the upper limb is getting adequate supply, but the lower limb is not getting adequate supply. So differential cyanosis means that upper limb is not going to show the cyanosis, but the lower limb is something that is going to show you the cyanosis. This is called as differential cyanosis. Okay, this is called as differential cyanosis. So differential cyanosis means it's going to be more in the feet rather than hands. And QP to QS ratio, similarly, like very similar to your VSTs, like it should be less than 1.5, then you will call it as small PDA. 1.5 to 2.2 is moderate, more than 2.2 is large. How will you diagnose it? So for any structure you want to see in the heart, you have to do a echo. So echo with the Doppler is something that is done, that is going to confirm the PDA. Next, chest X-ray, of course, it's going to be a pulmonary artery prominent, because a lot of blood is going to go to the pulmonary artery. That's why there is a pulmonary artery. And of course, there is an aortic knob which is there. And because a lot of blood is going to the lungs, there will be increased pulmonary marking, which is called as plethora. So let's quickly see these things if I have written. Yeah. So can you see this is actually arteriogram which I have told you. So what is going to happen? There is a descending aorta. So this is a descending aorta which is there. Okay, this is a descending aorta. Okay, so descending aorta is going to be there, and this is a MPA is what is MPA? MPA is actually main pulmonary artery. Okay, this is a main pulmonary artery. So can you see there is a connection between the two, and this connection is going to show you the patent ductus arteriosus. Okay, this is the patent ductus arteriosus aortogram. Okay, so have a close so what we do in that case, we have to do a closure. Okay, so what we do actually, we place a ductal occluder. Okay, ductal occluder is actually something which we place. There's a very small thin line. If you can just see this is a very small thin line. We have placed the occluder. Can you see these are these circles, and this occluder has been placed. Okay, so after placing the occluder, I have shown you. I think I have got the pictures of occluder as well. So see here. Okay, earlier we used to use this coils. Okay, so these are called as 𝗵𝗵𝗵𝗺 coils. Okay, earlier they were used. Okay, these are actually the stainless steel things, okay, which are used to occlude. Okay, so I was telling you about the chest X-ray. So I have told you that the pulmonary artery will be prominent because a lot of blood is going to be there. Now ECG in small PDAs is going to be normal, but because a lot of blood is coming onto the left side, in large PDAs there will be left ventricular hypertrophy as well as left ventricular axis deviation, because a lot of blood is coming to the left side. What will be the treatment? So if you remember, the cause of patency was prostaglandin E. So if you can inhibit this prostaglandin E, there will be closure. So what to do? Indomethacin and ibuprofen are the prostaglandin inhibitors which you can use, or you can use the percutaneous devices or the coils. You can do the surgery also. Okay, if the device closure is not feasible, you can do the surgery as well. But sometimes it's important to have a patent ductus arteriosus. Okay, sometimes it's important to have a patent ductus arteriosus. For example, if there is a pulmonary artery stenosis, sometimes if there is a pulmonary artery stenosis, okay, some children are there born with pulmonary artery stenosis plus patent ductus arteriosus. So their lumen of the pulmonary artery is very low. Okay, so in these patients, if there is PDA, please don't close it, because the lumen is very small and PDA allows a good supply, okay, to compensate the small lumen. So that's why it is actually good. So please don't do in some lesions which are duct dependent, and one of the examples is actually the pulmonary artery stenosis. Yes, complications like heart failure, endocarditis and pulmonary hypertension can be there, and pulmonary hypertension is actually increase in musculature in the pulmonary arteries that can cause the �𝗵𝗵𝗵 syndrome. This we have already discussed. So these all things we have discussed. Let's just quickly check what is the protocol. Okay, so what you have to do, let's just check the management approach of the patent ductus arteriosus. So we have got two scores actually. One is called as CS, another is called as ES. You don't need to remember them, but just you have to remember what is CS, that is the clinical score, and what is ES, that is the echocardiography score. Okay, so you have to check the risk. How? So based upon the clinical score, you have to classify it's mild, moderate and severe. If it is mild clinically, it's okay, no treatment is required. But if it is moderate or severe, you have to obtain the echocardiography, and then you have to check the echo, right? So just remember, not to remember the score, but just remember, if it is a closed patent ductus arteriosus, again there is no treatment which is required. Okay, and if it is not closed, then you have to go for the treatment pathway. That's it. And what is the treatment pathway? Sometimes we have to give the medical treatment. Okay, just like I have told you, indomethacin is something which we have to start. Okay, but indomethacin is not indicated in some of the conditions, like if the patient is having active bleed, if there is necrotizing enterocolitis. Okay, So in both these conditions, we can't give the indomethacin or the ibuprofen. Okay. In fact, in the intraventricular hemorrhage, because if there is hemorrhage and if you close the, the hemorrhage is happening, and if you give the indomethacin, so why indomethacin is not given in this case? Let's discuss. See, in necrotizing enterocolitis, okay, already the mucosa is going to get damaged. Okay. In IVH, already there is a lot of cerebral tissue death which is going to occur. Okay, because the hemorrhage and everything is happening. And if you just close, okay, if you just close the normal vessels, more mucosa damage is going to occur, more tissue death is going to occur. That's why indomethacin is not given. Okay, so if it is contraindicated, if it's IVH or NEC, then you have to do ligation. But if not, then you have to do medical therapy. Okay, but yeah, if there is failure to medical therapy, then you have to do the ligation only. Okay, then you have to move on to the ligation. So this was a small glimpse of patent ductus arteriosus, and in fact, whatever required for a UG perspective I have already discussed. So just one MCQ which you should never forget is the continuous murmur or the machinery murmur. Alright, so this is one of the most important take-home message from this entire chapter. So thank you so much for watching. We'll see you in the next video.